So I'm Steffi Stevenson, the Executive Director of the BC Pediatric Society. Thank you all so much for coming. Just let me remind you, there's food in the other room. There could be a bar as well. You could have a drink in here as long as you're really subtle. The most important thing to know is because we have telehealth sites, you need to push the little button when you're going to talk. So you'll see those little microphones in front of you. If you can make a point of pushing the button when you ask a question, then the telehealth sites can hear you, and that's really helpful to them. So let me introduce Dan Metzger. Dan is going to introduce our speaker for this evening. Thank you, Dan.
Thank you. I just got promoted to doing this. It's my pleasure to introduce Annie Sbrocchi, who is a pediatric endocrinologist at McGill at the Montreal Children's Hospital and the director of the bone program there, and also a person who does lots of gender stuff, and a person who does complex care, and is also affiliated with the Shriners.
Yes.
And she's a mother of 2.
Yes.
And she's kind of crazy. There we go.
Well, thank you for that colorful introduction. So it's a pleasure for me to speak with you today. We're going to talk about metabolic bone diseases, how to differentiate rickets, osteogenesis imperfecta, and hypophosphatasia, HPP, which is a lot easier for me to say. So I swear I did not bring the snow here to Vancouver from Montreal. In fact, it's actually 11 degrees today in Montreal. So at any rate, it's a pleasure to be here in Vancouver. So the objectives today are to identify the important components for pediatric bone metabolism, to differentiate various forms of rickets from other pediatric metabolic bone disorders such as osteogenesis imperfecta, which I will abbreviate OI, and HPP, which is hypophosphatasia, and then finally to discuss and approach the diagnosis and follow-up of pediatric metabolic bone disorders. So I will ask questions throughout the presentation, and I know all of you are going to be so eager to put up your hand and to shout out an answer, but I'm really just asking these questions to stimulate the thought process. So just keep the answers that I'm sure you will all know to yourself, unless, of course, at the end you want to discuss in further detail. I do have an honorarium that I am receiving from Alexion Pharmaceuticals for this presentation. So I thought I'd start with a case. So this is case number 1. We have a term baby boy born at 2.8 kilos, had a C-section, born by C-section because there were some intracranial calcifications and bony malformations detected on prenatal ultrasound. The APGARs were normal, but there was a little bit of mild respiratory distress at birth. And you can see that there's some shortening and some deformities of all the limbs. There were some skull depressions, and the baby had some polydactyly of both hands. These are the x-rays that were taken on the first day of life. So you can see that there's evidence of multiple in utero fractures with callus formation. So the ribs, you can see there's some calluses that are forming here. Similarly, in the upper limbs, there's multiple fractures with callus formation. You can see these lower limbs are completely deformed with callus formation as well. So the baby unfortunately passed away of respiratory insufficiency at a few weeks of life. So I ask you, what do you think this diagnosis was? So the diagnosis was osteogenesis imperfecta, and do you know what type of osteogenesis imperfecta it was? Type 2. So what is osteogenesis imperfecta? It's an inherited connective tissue disorder of usually COL1A1 or COL1A2, and these are genes that code for the type 1 alpha unit of collagen. There's multiple different phenotypes, but unfortunately there's no good genotype-phenotype correlation in most cases. There's about 1,500 mutations to date that have been identified, and about 85 to 90% are due to these mutations. Most are inherited dominantly, but some are recessive. So why does a connective tissue disorder with collagen result in a bone problem? Well, the collagen is part of the osteoid, and the osteoid, where the collagen fibers are, have to interlink properly with mineralized particles to form strong bone. So you can see that if the geometry is distorted of that interplay between collagen and mineralization, then you have smaller bone. So here is normal bone where you have nice thick cortices, nice number of thick trabeculae, or the spongy bone. But in OI, you can see that you have thinner bone. So 85% to 90% of the cases are known as classical OI, where the mutation is in COL1A1 or COL1A2, that codes for collagen. So the way you can think of severity is you go by 2, 3, 4, and 1. So type 2 is the type I showed you with that baby. So that is known as the perinatal or the lethal form, where there's multiple fractures, often in utero, and unfortunately, most of the time, the babies, if not picked up prenatally and initiated with bisphosphonate therapy, immediately can pass away. Then we have type 1, which is the most mild form. It may have the most consistent genotype-phenotype correlation. And it's known to be the most mild form of OI because the bone deformity seems to be quite mild. Usually the limbs are quite straight. However, they do have quite a few fractures. So even though we call it mild, it can still have a significant impact on the quality of life. They can often have vertebral fractures that can result in back pain, and they can have multiple long bone fractures as well. Dentinogenesis imperfecta, or DI, is quite rare as an association with OI type 1, but the classic blue sclerae are usually present. And then hearing loss is often present in these patients. So even if you see a child who's had a lot of recurrent fractures, the child themselves may not yet have the hearing loss because it tends to present later in life, but you can often ask about a family history of that because it's often present in 50% of the cases. So type 2 we already talked about, and so then type 3 is the most severe type after type 2. So these children have multiple fractures, have severe bone deformity, are very short. These children, unlike type 1, have DI, or dentinogenesis imperfecti, but in terms of sclerae, they're usually blue at birth, but then they actually look normal in terms of the sclerae of the eye, and hearing loss is frequent. Type 4 is somewhere in between type 1 and type 3. So the severity is kind of in between the two. They can present with multiple fractures. Bone deformity is mild to moderate. They're variably short. And instead of blue sclerae, these children and individuals tend to have gray sclerae, and there is some hearing loss. So just remember 2, 3, 4, 1 in terms of severity. And here are some pictures to illustrate these individuals. So here's a child with type 1. So remember the most mild form. So often the limbs are straight, but they have multiple fractures. And here you can see that she's hooked up to an IV, probably for her intravenous bisphosphonate therapy. So bisphosphonates have been shown to help reshaping of vertebral fractures, which is quite unique in this condition with bisphosphonate therapy. Normally your bones in the spine are nice square-shaped vertebral bodies, but when you have fractures, they're smushed. With a growing child and bisphosphonate therapy in a child with type 1, they actually reshape, which is very unique to children. And then the bisphosphonates will help prevent more long bone fractures as well. Type 3, so you can see here, there are some bowing of the legs. And they often have this facial phenotype. It's very common, actually, we see as typical faces in type 3. And then here in type 4, you can see this child can walk, but does need the assistance of a walker. Here are the skeletal manifestations I was talking about. So here are the vertebral compression fractures. So instead of a nice square, you can see that here's some wedging, which does happen to reshape with the vertebral body after receiving zoledronic acid, for instance. That's what the typical bisphosphonate of choice now at the Shriners. Here are the deformities I showed you. And then the other thing we often see are Wormian bones. So these are just centers of extra ossification in the skull. And usually if we say there's more than 10, then that may be a clue that OI is present. But having said that, you can have individuals with 10 Wormian bones and don't have OI. Scoliosis is also present, often in OI. So again, if you have a child school-aged with a few fractures and scoliosis, maybe you should start to think of OI as well. There are some extraskeletal manifestations of OI. So if you all try to take your finger and bring it all the way down to your wrist, you'd have a hard time doing that. But if you can do that, you have ligamentous laxity. So I said it's a disorder of collagen. So the collagen is very lax in OI. This is the classic blue sclerae that we see in type 1 in particular. And so that sums up the main features I wanted to point out for OI. So now we'll move on to case number 2. So this is an older baby now, a 4-month-old with short stature, who presented with short and bowed lower extremities, muscle hypotonia, a bulging anterior fontanelle. A skeletal survey was performed and showed that there were mineralization defects of the long bone, cupping of the metaphyses, demineralization of the skull, a normal chest x-ray in this case. So if you were to do some basic biochemistry for bone and mineral metabolism, what would you think of doing? So the answers would be calcium phosphate, alkaline phosphatase or ALP, PTH, and 25-hydroxy vitamin D. And I mentioned 25 because that's your marker for your vitamin D stores. So these were the results that were obtained for this baby. So the ionized calcium was 1.6, upper limit being 1.29. Your phosphate, magnesium, and your stores of vitamin D were all normal. So initially you might have thought, oh, well, this baby has rickets. Well, maybe not. And the ALP was 7, with the normal range being 150 to 240. So what stands out to you? The ALP, I hope you all realized. So what was interesting for this baby is that the past medical history was also remarkable for seizures refractory to treatment with phenobarbital and phenytoin. And the baby also had a renal ultrasound which showed some medullary nephrocalcinosis. So what does that make you think of? The answer? Hypophosphatasia, not to be confused with hypophosphatemia. So they're completely different entities. So I'm going to call it HPP because it'll help me speak more for the rest of the presentation. So this is an under-recognized, life-threatening systemic, and I want to highlight that it's a systemic inherited metabolic disorder. It was actually first discovered in Canada in the early 1900s, and then in 1987, Cheryl Greenberg out in Manitoba actually found one of the first genes that's associated with this disorder. Because there's quite a large population in the Mennonite community that have HPP. And since then, many mutations have been identified in the gene ALPL, which encodes the tissue nonspecific ALP isoenzyme, which can result in undermineralized bone, along with several other manifestations. So there's different forms depending on the age at presentation of some of the symptoms. So the perinatal or infantile form presents less than 6 months of age, so that's as in our case. There's the juvenile or childhood form, so that presents anywhere from 6 months to 18 years of age. The adult form, which is over 18 years of age. And then there's what's called the dental form. But having said that, the dental form can often overlap with some of these other forms as well, particularly the juvenile and the adult form. So we're going to talk about all of these in a little bit more detail throughout the presentation as well. So in terms of mineralization of bone, most of us know we need calcium, phosphate, vitamin D to mineralize bone, but we don't think that ALP is actually a key player also necessary to mineralize bone. So why is that? Well, ALP, so tissue nonspecific ALP, is produced by the osteoblasts, and normally it dephosphorylates inorganic pyrophosphate, releasing inorganic phosphate. Inorganic phosphate is then going to bind to calcium to form hydroxyapatite, which is there to mineralize your bone and make them nice and strong. However, in HPP, your ALP is mutated, so it's not working properly. So you get elevations of inorganic pyrophosphate. Well, inorganic pyrophosphate actually blocks hydroxyapatite crystal growth. So your unmineralized bone matrix accumulates. You can't have it mineralized. So you get all of this soft osteoid that's not being mineralized, and that results in rickets, bone deformation, osteomalacia, and weakness. In addition to accumulation of inorganic pyrophosphate, there's other substrates that are normally hydrolyzed by tissue nonspecific ALP. And one clinically important one is PLP, or pyridoxal 5' phosphate. So normally in the CNS, ALP would dephosphorylate PLP into pyridoxal. And pyridoxal is really the most important form of vitamin B6, because then this form of vitamin B6 can cross the blood-brain barrier for your brain cells to be happy and healthy. However, if you can't get pyridoxal into your CNS, then the CNS system is not happy and seizures can occur. And so if there's a baby who has seizures, but you give vitamin B6 back and they respond to this, and then you later find out that it's because the baby has HPP, it's a very fatal prognostic indicator. And actually in this case, the baby that I showed you, unfortunately the baby passed away shortly after the age of 4 months, and the baby did have seizures. So ALP, it's so crucial to measure it, but it's so crucial to use the proper reference range. So ALP, based on the Caliper project, which looked at obtaining normal median reference ranges for age and gender, showed that ALP certainly increases with puberty, right? You're growing quickly, that's the time of rapid growth. So it's really important that the ALP is compared to somebody of the same age and sex. For instance, if I had a 10-year-old girl and her ALP was 60, and I plotted her at an adult reference range, I would say, oh, 60, that's normal. But if you used a proper reference range, you would then see that 60 is actually indeed low. So it's so important to make sure that your lab has the proper reference ranges. And especially if you're sending out samples to outside labs that don't have pediatric adjusted reference ranges, then make sure that you make the adjustment for that. So HPP has some specific radiographic findings. Generally speaking, though, most of them resemble many of the other disorders of bone mineralization that you can have, right? You can have metaphyseal flaring, fraying, physeal widening, osteopenia, long bowing, fractures, very nonspecific, but I do want to highlight one pathognomonic finding that you can see on X-ray, and these are radiolucent tongues. So what do those mean? So basically you have areas of sclerotic bone and areas of hypodense bone. So I guess you could imagine this looks like a tongue, but at any rate, I didn't coin the term, but these are called tongues of radiolucency. So it is one of those pathognomonic findings that you could see on X-ray that could give you a clue that this is HPP. The other thing I want to point out is that you definitely have progressive skeletal demineralization. So this is a baby, so with the early form of HPP, and you can see that over time, there's more and more demineralization, widening of the growth plate, more lucencies, and femoral bowing. So speaking of femoral bowing, we're going to move on to another case. So here's case number 3. This is a 12-month-old boy with bowed legs. So I ask you, why can bones bend like this? Well, it's simple. I know you may think it's not simple, but it's simple. There's either not enough mineralization or there's a skeletal dysplasia, as in osteogenesis imperfecta. So why would there not be enough mineralization? So that tends to be any form of rickets or osteomalacia. And it's important to differentiate rickets from osteomalacia. And the difference is that in rickets, you have not enough mineralization and the growth plate is open. The child is still growing, or it's a part of the bone where the growth plate is affected. Whereas in osteomalacia, the growth plates are closed. So this tends to be more in the diaphyses of the bone or in any of us. Presumably we're all done growing, and I unfortunately am not I'm done growing, so that's why I wear heels. At any rate, no matter what the cause of rickets is, the phenotype is similar. And so it's tricky sometimes to see just on a physical exam, well, what's the cause of the rickets if it's due to decreased mineralization. So what is this phenotype? So if we do a head-to-toe approach, so there's the delayed closure of the fontanelles, there's frontal bossing, there's wide sutures, craniotabes, or it kind of feels like a squishy ping pong ball. The teeth are affected, the enamel in particular. The costochondral junctions, you can see little bumps, if you will, so it's called a rachitic rosary. There's a bit of a pectus carinatum, swelling in the wrist and ankle joints and bowing of the legs, as well as this Harrison's sulcus, and that's just the pull of the diaphragm with the weaker bone. You can kind of see a pull right there. And so what's interesting is most of these findings are all at the level where there's rapid turnover at a growth plate level. And so that's why the main features are seen there, because where there's rapid growth, where there should be lots of bone turnover and bone mineralization, you just have an accumulation of that osteoid and unmineralized bone. So the classification of rickets. Classically, everyone's learned, well, it's either calcipenic or phosphopenic, but now there's actually a new mechanistic approach to rickets. So column 1 here has really been replaced, the calcipenic term has been replaced with PTH-mediated rickets. And then columns 2 and 3, which were classically considered phosphopenic rickets, have been replaced with the mechanism of either being a problem at the level of the kidney or FGF23-mediated rickets. So if we start with PTH-mediated rickets, all of these causes of rickets result in high PTH. So anytime you have vitamin D deficiency, whether it be poor intake or malabsorption, as in celiac disease, your PTH will go up. If you have a disorder, a genetic disorder of vitamin D metabolism, such as a 1-hydroxylase deficiency or a vitamin D receptor problem, your PTH is going to go up. If your calcium is low, your PTH is going to go up. So really all of these result in high PTH, which is going to rob that calcium out of your bone because it's going to increase bone turnover. If we look at the phosphopenic classification, which has been changed now to a problem with the kidney or FGF23, well, at the problem of the kidney, it's a tubule problem. So it's the sodium phosphate co-transporter that tends to be affected, or renal failure like in Fanconi's anemia, and then you can have some rare genetic forms. I do want to draw your attention to this hormone FGF23. So this is a hormone that really helps to regulate phosphate. And so if FGF23 is high, it works on that sodium phosphate co-transporter in the kidney to push out phosphate from the kidney. So the most common form of inherited rickets is X-linked hypophosphatemic rickets. So it's a problem with the FEX gene, which seems to have a regulatory effect of FGF23, so your FGF23 is high. Then you have autosomal dominant hypophosphatemic rickets, where you just have way too much FGF23. So FGF23 is going to push your phosphate out of your kidney. Then you can have the autosomal recessive form, which is a problem with DMP1, again resulting in high FGF23, pushes phosphate out. What's really interesting is this entity called tumor-induced osteomalacia, and Leanne Ward, who's my mentor, published a paper where they had a girl who had a tumor in her bone. And when they resected the tumor, the rickets got better. And it turned out when they looked at the pathology, that tumor that was in the bone was overproducing FGF23. So when it was taken out, the rickets went away because the FGF23 was no longer elevated. And then you have some other rare forms of FGF23-mediated rickets. So really, the calcipenic has been replaced with PTH-mediated, and then the phosphopenic has really been replaced with either a problem intrinsic to the kidney or an FGF23-mediated process to help leach the phosphate, but both of these leach phosphate. And this is a slide just to illustrate that all of those genetic disorders result in high FGF23. So FGF23, as I mentioned, will increase phosphate at the kidney, excretion of phosphate at the kidney, but we all know that PTH will also do the same thing, right? It also increases phosphate excretion at the level of the kidney to a lesser degree, however. It's really FGF23 that's the main player. But I do want to point out that FGF23 actually decreases the 1-alpha hydroxylase activity. So normally at the kidney, your 25 vitamin D gets hydroxylated to have the 125 added, and it actually decreases this. And so if you don't have the active 125 form of vitamin D to absorb calcium at the level of the intestine, you shouldn't have any effect on, increasing calcium. Whereas PTH does the opposite. It actually upregulates 1-alpha hydroxylase. So that's actually going to increase your active form of 125 vitamin D, which is actually going to increase calcium absorption. So although they both work by increasing phosphate excretion at the level of the kidney, FGF23 actually downregulates your active form of vitamin D, whereas PTH upregulates your active form of vitamin D. So that'll have implications when you're doing your bone biochemistry that I'll show you shortly. No matter what the cause, though, of rickets is, whether it's PTH-mediated, a problem at the level of the kidney, or FGF23, the common denominator in every single form of rickets results in low phosphate, right? Because even if you have a PTH-mediated form that's pushing the phosphate out of your kidney, your phosphate will drop. And in the other forms, whether it be at the level of the kidney or FGF23 mediated, your phosphate is going to drop. Well, what happens is low phosphate actually decreases apoptosis of chondrocytes. So those chondrocytes just keep on proliferating. There's no mineralization occurring. And so you get widening of the growth plate, which you can actually see correlating on X-ray. So if we go back to that little boy who had the bowing of the legs, and you take a good history, you find out that the perinatal history is unremarkable. The baby was exclusively breastfed with no vitamin D, had 1 tibia fracture after minimal trauma, has no medication, does not have any diarrhea, is African American, healthy family, and just started walking 2 weeks ago. So what are your thoughts? This one should be pretty obvious. If we look at all the risk factors, likely diagnosis, nutritional rickets, or a PTH-dependent form of rickets from a lack of vitamin D. So this baby, we can say, has rickets. And rickets is truly an X-ray diagnosis. You can't really say it's rickets just based on biochemistry alone. You usually have rickets, which can increase your risk of fracture. And you see rickets on X-ray. But you can kind of see the warning signs, if you will, that could lead to rickets, and that's when you look at your 25 hydroxy vitamin D level. And so the adequate amount you need of 25 hydroxy vitamin D is about 50 nanomoles per liter. I know there's been a lot of controversy in the literature. Is it 75? Is it not? Well, for bones, you don't get into problems with your bone. A level of 50 is perfectly adequate. Where did this 75 come from? Well, the 75 came from showing that it was the level at which point your PTH is suppressed. But do you really need to suppress your PTH? Because when your PTH just kind of goes up and down, it's actually anabolic for bone, right? We give it to adults for osteoporosis. However, when your PTH is chronically elevated, that's when it's always robbing the calcium out of the bone. So for no problems with your bone, a level of 50 is fine. There may be some benefit to having a little bit more, but again, the studies are still ongoing for autoimmune diseases and cancer risk and all of that, and the evidence is quite weak, I have to say, but generally, we target 50. Insufficiency is anywhere from 30 to 50, and deficiency is 30. But you may just have vitamin D deficiency, and you do an X-ray, and there's no signs of rickets, and there's been no signs of fractures. You're still going to treat the vitamin D deficiency, but you wouldn't label that child as having rickets. However, if rickets is there, then that's a different story. And I said earlier that we look at the 25 hydroxy vitamin D for your stores. Well, why is that? If you were to measure a 125 vitamin D, remember PTH increases that 1-alpha hydroxylase. So if your PTH has been turned up because you're trying to maintain calcium, normal calcemia in the level of the blood, and you just measure this is going to look high. It's going to look high because it's upregulated your 1-alpha, right? So you actually want to look at what your stores are doing. And in addition, this half-life is very short. It's very fluctuant. So you really want to know what are my stores doing at the level of the liver. And then there's the whole issue, do I replace with D2 or D3? Well, D2 is a plant-based vitamin D, so some vegetarians that are taking vitamin D, if they're strictly vegetarian, you should tell them, well, if you're taking vitamin D3, it's actually coming from animal. So if you don't want anything animal in your system, then make sure they take vitamin D2. Otherwise, if it's carnivore or anybody else, you go ahead and give the vitamin D3. There's no difference on a daily basis if you're supplementing with vitamin D2 or D3 in terms of getting your level up. And a general rule of thumb is that if you're taking at least 1,000 units a day, your level of vitamin D should increase by about 25 nanomoles per liter after 3 months of treatment. However, if you have a non-compliant teenager, which is often the case, and you want to just give them a pulse dose, let's say, of 10,000 units once a week, the vitamin D3 will actually have their levels stay up for a longer period of time versus the D2. So just something to consider in terms of your treatment regimes. If, however, they have full-on nutritional rickets, so there's radiographic changes, there's a global consensus that came out, put out by Craig Munns in Australia, and his group, who have put forth the following recommendations. So if you have a little baby, you want to treat for at least 90 days with a minimum of 2,000. I mean, we've given more before. It's not going to harm them. And then after 3 months, you go down to a maintenance dose of 400. If they're older than a year after you give a nice dose, a high dose of vitamin D, then you can drop down to, I think, what's generally recommended on our guidelines in Canada for a minimum of 600 thereafter. Now, you have to ensure, though, that there's a daily calcium intake that has at least 500 to prevent hungry bone. So it's really important to always supplement the two together. So let's do a little variation on that case. Which was so classically obvious to have the 25-hydroxy vitamin D deficiency. In this variation, we see that the vitamin D is normal, but the phosphate is low. So you would have to add a few more things to your additional workup. So what would they be? You're going to have to look at the urine. Basically rule out kind of any intrinsic defect at the level of the kidneys. You can calculate your tubular resorption of phosphate. And basically, when you calculate this, it's really just telling you that if it's less than 85%, there's phosphate wasting, either FGF23 mediated, either renal mediated, or a high PTH effect. So all of them are there. So it's not the most helpful without checking the other parameters in your urine. And then you might think, okay, well, maybe there's not enough phosphate getting in the diet if there's no phosphate wasting in the urine, as we see sometimes with the premature babies who are at risk of osteopenia of prematurity. If they're on certain formulas that don't have enough phosphate, then you might start to think, okay, well, maybe I'm not supplementing enough and they're not on the proper formula. So bottom line is labs are very helpful. So we're going to review them here. So we talked about HPP earlier, and you can see that for HPP, it's so critical just to do a basic ALP, right? Your ALP is going to be low. Your calcium, as I showed you, could be high or normal, because remember that enzyme is not breaking down your inorganic pyrophosphate into inorganic phosphate. So if your inorganic phosphate isn't there to bind to your calcium can come up a little bit, right? Your phosphate can be high or normal, and your PTH is low or normal. So that's the hallmark for HPP. However, with nutritional rate hits, which is PTH mediated that we went over, your ALP is going to be high, right? Because PTH and ALP are going to be revved up for bone turnover to try to liberate that calcium out of the bone to maintain eukαλσemia, and your stores of vitamin D are going to be low. They can be pretty much anything in HPP. With X-linked hypophosphatemic rickets, as in FGF23 mediated, your ALP is going to be high because you're having high bone turnover, but your vitamin D is normal. Your PTH is normal, but your phosphate is low. So your calcium is normal because these are normal. So really, you're looking at your phosphate and your ALP. And finally, with osteogenesis imperfecta, everything is normal because it's not a disorder of bone mineralization. It's a collagen problem. So you can still normally mineralize your bone, but it's just that collagen there's not enough of it, or there's enough of it and it's mutated. So it's just not cross-linking properly to form nice, strong bone. So labs are very, very helpful to differentiate these skeletal disorders. So they can all present, though, with short stature, bowing, and fractures. So remember, even if you have a child with just short stature, still think of HPP. It's in the differential. So while you're waiting sometimes for these labs to come back and you're performing your physical exam, there are some other clinical clues you can look at. So as we often say, the eye is the window to the brain, the teeth are the window to the bones. So with the teeth, as I talked about earlier, with osteogenesis imperfecta, you can have dentinogenesis imperfecta, right, which was rare in type 1, but more commonly seen in the type 3 and the 4. And so that you have this kind of translucent beige discoloration of your teeth, and it pretty much impacts most of your tooth. Whereas in rickets, let's say vitamin D deficient rickets, there's poor calcium that is there for the enamel. So you have enamel hypoplasia. It tends to just kind of affect the ends of the teeth. So the teeth can give you a lot of clues to what bone disorder you're dealing with. And the most important thing about the teeth relates to the juvenile onset form of HPP. So juvenile onset is anytime from 6 months onward. And so 99% of patients with juvenile HPP will lose a premature tooth before the age of 5. And I'm not talking about the type of tooth that you put under your pillow for the tooth fairy to come and give you money. And I don't know what the going rate is. When I was a child, it was 25 cents. I think it's been like jacked up to a toonie now. That's what my kids think anyways. At any rate, so the tooth, typically, when a child loses it, right, the root is not there. But if there's no trauma and the child before 5 loses a tooth with the full root intact, you should have a very, very high suspicion for juvenile onset HPP. And why does that happen? Well, you need that ALP enzyme to mineralize your tooth, and that mineralized cementum of the tooth needs to attach to your bone. If not, it can just fall right out. And so often these first middle teeth are affected, but really any tooth can be affected. But if you start to see this early, you really have to think of HPP. So why is it so important to accurately diagnose HPP? It's important to diagnose everything else that I've talked about, but in particular, why? Well, if you're looking at the infantile and perinatal form, there's a very high mortality rate. And in fact, there's 100% mortality rate in the Mennonite population at 4 years of age. But you can even see with this natural history study, even at 4 years of age, 73% of these children were dead. So it's quite significant, especially for the early form. And what I really want to highlight is that even if it's a child who doesn't have the perinatal or the infantile form, the juvenile or childhood form and the adult form can have many, many morbidities at any age. So no pediatrician and no specialist in pediatrics is exempt from having to be more aware of this disease because it is out there. The infantile form obviously is very severe and more pronounced, but look how nonspecific some of the symptoms are for the juvenile or the childhood form. Bone pain, chronic bone inflammation, short stature, tooth loss, but remember the root has to be intact, or poor dentition. These are all very nonspecific findings. And even if they don't have all of these early on, they can still develop them. So it's important to think of early on and then monitor them over the course of their illness or their condition just to see what other symptoms may or may not develop. And here are some more systems that are involved. So the kidneys can be affected. Remember that calcium could be mildly elevated, so they can have nephrocalcinosis. They can have hypercalciuria. They can have stones that result in pain. The muscular system is particularly involved, and many of these patients may actually be referred to rheumatology first for muscle pain, or they're not walking as they should. And this can still prop up later in the adult form. And they can have joint pain and pseudo-gout. So really no specialist is exempt from really having to be aware of this disease to see what can happen. And so why is it so important to diagnose, not only for all of the morbidity that's associated with it, but you don't want to give calcium and vitamin D like you would in rickets, because I showed you your calcium can come up. And so if you're giving more calcium, you're just going to exacerbate the condition. Bisphosphonates in particular are analogs of inorganic pyrophosphate. Well, I said there's high inorganic pyrophosphate that is going to block mineralization. So if you're giving a bisphosphonate, you're actually going to exacerbate the disease further as well. So that's why it's so important that this disease entity gets properly diagnosed. So along came Strensiq, or S-phosphatase alpha, which was actually discovered in Montreal. So Quebec's not bad all the time. So it was discovered in Montreal, and it's the first and only enzymatic replacement therapy for HPP. And so S-phosphatase alpha is the first bone-targeted human recombinant tissue nonspecific ALP fusion protein. Other attempts were made to make ALP. It made sense, right? I'm missing ALP. Okay, let's give back ALP, but it didn't work because it didn't actually get to the root of the problem, which was in the bone, in particular for these patients. And so it has a 32-fold greater affinity to the purified hydroxyapatite based on how it's made molecularly. And so since this came out, it's really changed the course of treatment and the course of the illness, especially for the perinatal or the infantile form. So there's many studies that have come out to show its effectiveness, both in the perinatal infantile form, but also for that juvenile form. So here is a study with 37 treated individuals with S-phosphatase alpha compared to 48 historical controls. And you can see that their survival was overall improved. And not only was it improved, but most of them actually came off the ventilator in the first year of life, which was quite revolutionary for these kids. So the NICUs have to think about this entity as well, right? You have sometimes these babies you just can't get off ventilators. Well, you have to also think of HPP. And then in terms of the rickets, after just 24 weeks of treatment, you can see that there was remineralization of the ribs, the clavicles, the spine, and the scapulae. And that here, the mineralization of the phalanges occurred quite nicely. So without treatment, none of this would have happened. So I know you know at least one condition now that has low ALP. But can you think of 3 in total? Because, you'll see low ALP pop up. Yes, there may be hypophosphatasia present because you may have the fractures, you may have bone pain or seizures in a baby or many of the other things I've shown you. But if there's none of that and you see a low ALP, what could it be? Well, there can be nutritional deficiencies. In anorexia nervosa, you can have low ALP, vitamin C deficiency or scurvy. Celiac disease. Steroids are quite notorious for turning down your ALP, bisphosphonates, multiple myeloma or other cancers, and major trauma or surgery. So it's important to remember other causes of ALP in addition to hypophosphatasia. So in summary, calcium, phosphate, vitamin D, and ALP are needed to mineralize bone. The clinical presentation of HPP can resemble other skeletal dysplasias and is thus commonly misdiagnosed. Low ALP activity is the diagnostic hallmark of HPP, and it's really important to differentiate it from other disorders in addition to all those other biochemistry parameters I've shown you earlier. And it's very critical to consider this in the differential diagnosis of various metabolic bone diseases because it is treatable, and if you give the wrong treatment, you can exacerbate the condition. So I'd be very happy to end this session with any questions from other centers or discussion in this room. And I thank you very much for coming, especially with the snowy evening we've had tonight. And I did not bring it, I swear I didn't. Thank you.
You have to use your little.
I have a lot of questions. My name's Anna Maria. I'm a newly graduated pediatrician, and I'm working in both complex care and metabolic, so I get a lot of these referrals. What do you consider a low ALP?
So the question is, what do we consider a low ALP? Well, you have to look at it for the age and gender matched reference range.
Yeah, but do you consider like a 140 low, or do you...
You really have to look at the age and gender matched reference range.
Age and
Yeah.
matched gender reference range. Like, does it have to be quite low?
So, I mean, there's no rule of thumb, but generally 70, you really start to be more suspicious. But you really, like I said, I don't want to give you a cutoff because you really have to look at that age and gender matched range.
Borderline low or low?
It's usually quite low, but if it's borderline low in conjunction with those other manifestations of HPP and they don't have a nutritional deficiency, they don't have multiple myeloma or cancer or anything else that you would worry about as an additional cause of ALP, then you should certainly continue potentially genetic analysis and get your genetic colleagues to send out.
So that was my next question.
Yeah.
So say your hypophosphatasia is on your differential. what would be your next step in terms of investigation?
Yeah, so then I would consult my colleagues in genetics and ask them to do a send out for genetic testing for HPP to see if they can identify one of those mutations in the tissue non-specific ALP. Does that answer your question?
For us, it would be biochemical genetics, biochemical diseases, right? Yeah.
Which is you. So, I mean, if you need help, you can always contact us in Montreal. We have Fabienne Parent, who will be happy to tell you exactly who to send it to. She's our biochemist there. I know Sick Kids also sends out testing for HPP as well.
Yeah, I mean, I've ordered a lot of ALPL gene testing for sure, but I have so many referrals that come in for nothing really clear, failure to thrive.
Failure to thrive.
Delayed motor skills with an ALP of 135. And it seems.
And what's the reference range, though? What's the lower limit on that reference range?
Usually just right below the lower limit of normal. It's not.
So I'd probably at least repeat it at least once, just to get a sense, right? When in doubt, repeat. And then if it's still low and you're still suspicious, you don't want to miss the diagnosis. So I would send off the genetic testing because it is so crucial to treat because there is a lot of morbidity associated with it.
Yeah, and the importance of, the other test that we do is the pyridoxal phosphate, I think, right?
Yeah, you can do pyridoxal phosphate, check the urine and yeah.
Is there, would you consider doing the pyridoxal phosphate before going to gene testing?
I would probably do both at the same time. If you're really suspicious for it, I would just do it all together.
All right, thanks.
Does that help?
Yeah.
Yeah? Okay. Any other questions? Yeah.
So what is the just dosing for, I'm still just not rock solid sure. It's easy to start off 400 units for babies. And when
for vitamin D, okay. Yeah, dosing for vitamin D.
When should one move up to 600 units?
Okay, so that's a really good question. So I put all babies on a minimum of 400, whether they're breastfed or bottle fed, because they need to drink a liter of formula a day, which I think is a significant amount for any baby. And I think our first job as pediatricians is to prevent rickets, and you're not going to get into trouble if every baby is on a minimum of 400. After a year of age, if the total that they take in their diet, whether it be food and supplements, equals about 600, then you're fine. If it's a child who drinks no cow's milk that's fortified with a little bit of vitamin D, you could put them on 400, you could put them on 600, you can even go up to 1,000. They're not going to get into any trouble. So, at least if the minimum that you give them is 400, thinking maybe they get another 200 with any bit in their diet, they should be fine. There's no reported cases of rickets with anybody on a minimum of 400, but we've just expanded the upper limit to 600 total, both diet and supplementation, because that's really where we've seen 97% of individuals have a level of 50 nanomoles per liter where you don't get into trouble with your bones.
Secondly, what do you feel about the link between asthma and vitamin D deficiency? There's certainly been a lot in the literature about it and a lot of lack of certainty.
Yeah.
And so dark-skinned children clearly they should be supplemented anyway. But what do you feel about the
So
link?
the link between asthma and vitamin D, it's a good question. I'm actually going to be collaborating with a study being led by Francine Ducharme from St. Justine Hospital, who just got funding through CIHR to look at that in more detail. So hopefully we will have some more objective evidence shortly. Right now, I don't know if we have enough evidence to say if there is a link between vitamin D and asthma. I think there's much stronger evidence for family history of atopy and allergies, and family history of asthma, I think, is really where the money is. And I think vitamin D, it's not going to harm to give it. So just give it and see what happens. But I don't think there's enough evidence to say there's a link just yet until we have more concrete data, but it is coming.
And Connie Yang is part of this.
Connie Yang is part of that. Your site PI here, or asthma person here. That's great. So we should have more data eventually, but right now I can't with certainty by any means say that there's a link between vitamin D and asthma.
What about vitamin D and MS? Because
vitamin D and
MS goes up steadily as you leave the equator and go north.
Yeah. So again, there was a review, a Cochrane review, I think that was put out a few years back to look at all of the links of vitamin D and its impact on various diseases, including MS, and there was not even any probable or potential evidence. I forget the term they use, but there's really very, very little data to support vitamin D a deficiency with any main condition, except dental caries, I think, came out as one of the big ones. think that was the main thing that sticks out to me in terms of the pediatric population. I think there was a few other parameters that were more adult related, but again, it's not going to harm, so just give it. Same thing with diabetes, right? There are these autoimmune diseases. I mean, vitamin D is truly a steroid hormone, so I'm sure there's some interplay that's important with vitamin D, but I think it's important just to supplement everybody, and I think genetics will really take over and figure out the rest. Other questions? Is there a way to, do I have to push anything for them to
Are there any questions
ask?
from are there any questions from Vernon, Victoria?
Your leg's coming on.
Oh, sorry. Vernon, Victoria, Viha. Anybody got questions? Hi, everybody. You're all good. They're way smarter in the suburbs, in the up north.
Because they're all on vitamin D, right? Because they're
right.
above that latitude where you should be on like 800.
Oh, I've turned it off.
So clearly there's a correlation between how high up north you live and your intelligence. No.
Is there any role for doing the old-fashioned the bone burns, the subtyping of alkaline phosphatase if you're not sure?
Oh, like to know if it's placenta ALP or liver ALP or
Yeah.
bone ALP? If you can, I guess so. But again, like I showed, it's a systemic disorder. So even if you have elevated ALP in the bone, you don't know necessarily what other systems might be affected because it is such a systemic disorder. So I think there's still more work to be done to figure out what's the best methodology for screening. But I think right now, even just a total ALP is fine. So I don't think there's any need to subdivide further just because it doesn't just affect the bone.
Do you see many cases of HPP that have been missed for a long time?
No, because it's rare. It's about 1 in 100,000. And I think there hasn't been enough awareness to know that it's been missed. So we're trying to make sure they don't get missed. And it's funny that you asked me if there have been any missed cases, because right now at the Children's Hospital Montreal, we're actually meeting next week. We went through the past 7 years. We've extracted from a database all the low ALPs. And then we're going to meet, because I think many have been found, and we're going to look at their charts to see if they were potentially missed. So there will be more data coming out just to get more concrete evidence. And I think as we increase awareness, we're hoping not to miss these cases because it is out there. We just need to make sure we're more aware of it. I think we've classically been taught, high ALP, it gets flagged. But low ALP, if it's not done with the proper reference range, or if it's not flagged that it could be a serious mineralization bone problem, I think, we've been missing them. So I think hopefully we won't miss them. But we don't have that data just yet to know how many have we missed. There have been cases. I mean, you have anecdotal cases from adults who said, I was diagnosed with chronic recurrent multifocal osteomyelitis. I had all this pain. Nobody knew what the problem was. I got bisphosphonates. I was worse. So you get anecdotal evidence here and there for cases that were missed. But in terms of a study, we don't have that yet.
How about missed cases of OI? Do you see that?
Missed cases of OI. Missed cases of OI. Well, I don't see them because I work beside the Shriners, so they already come to me diagnosed. So I can't answer that question because they already come because of the bias referral base I have. But it would be interesting to look back and see how many, and I guess it would depend on the severity. And like I said, there's no good genotype-phenotype correlation except for maybe type 1. So again, I think some are being missed unless it's obviously very severe early on. But I'm sure there's type 1s that are being missed.
I think sometimes the parents have been missed.
Absolutely.
Yeah. So you'll see it in the parents. It's like, oh yeah,
Parents can be missed
1,000 times as a kid. Nobody knew what it was.
Yeah.
Right?
Oh yeah. I always examine the family members when the child comes into my office. If I'm being referred somebody for recurrent fractures, I have a quick glance at mom and dad just to get a sense too and see. So I think there might have been 1 or 2 at CHIO with Leanne Ward in Ottawa who she figured out. Okay, yeah, the whole family has this, and then ends up doing genetic testing for the whole family. So. But where I work, they've already been diagnosed, so I don't get that often. Yeah.
So I work in the area of child abuse.
Trauma X.
And unfortunately, OI comes up
Yeah.
an awful lot with us too. In terms of the genetic testing for it, we get reports back that say that the genetic testing excludes it with a certainty of 95%.
Yep.
What do we do about the other 5%?
It's really rare in those cases that OI is the cause of the fracture. So that other 5%, I would pretty much, unless you have other obvious findings of OI, probably exclude it.
Yeah, I mean, most of these are cases where there are multiple fractures.
Yeah, multiple
Sometimes
fractures. It depends where the fractures are.
Yeah.
Are there vertebral fractures or not?
Yeah,
If there's
they
not,
tend
and you
not to
have a
be.
clearly like a nice buckle a handle fracture, so it all depends on the clinical picture as well. But chances
Yeah.
are OI.
really low. Yeah, because
Really,
unfortunately,
really low.
I'm usually sending off testing for the kids that I'm highly suspicious that this is non-accidental injury. They have other systems involved as well, but because of the legalities, the medical legal side of it, we're really forced to go the distance. And I was really interested because just today I received an email from one of our geneticists that has two of the names that you put up there that work at the Shriners for a second opinion on a case that's active right now.
Interesting. Okay. It's really rare. The literature shows it's really rare to have OI in those cases. Obviously, if it does come up, it changes everything. So you don't want to miss it, but usually there's some other clues to figure out if it's truly OI or not. Good history, a physical, like any good physician. But, you can just say, in my professional opinion, the most likely cause is non-accidental trauma. The most likely cause. You never say the cause is, right? So you just have to word it creatively so those lawyers don't put you in the hot seat, which is an art in itself.
Annie, the rare form of OI that's in Aboriginal people, is that autosomal recessive?
Ooh, I'd have to look back because it's not in the silence classification of type 1 to 4. I think that's like one of the
7 or 8.
Yeah, we're up to like 9, I think now. Is it recessive? I'd have to look back. I don't remember offhand. I'm sorry.
Yeah.
I
I'm
don't
just
know.
wondering if there's any other like non-bone things that Nita could look for, other than what you talked about for the rare forms of OI, the other 5%
Oh.
get picked up. It's bone biopsy stuff, right?
Yeah, I
There's
guess you'd be
nothing
looking at
like you
that.
can just see from looking at them.
Because you've done your skeletal survey, you've done all your biochemical parameters. Depends where those bone fractures are, the history, if it's changing. Yeah, non-accidental. So, I mean, it's really rare to find a rare cause of OI, but I'd have to dig up the literature and look at that in more detail because it really ends up going to my child protection team. And I don't really get involved with those kids. Yeah. Any other questions? No? Clear? Yeah, hope everybody had fun. I had fun. It was so nice to be out here in BC, so thank you for having me.
Thank you.